My name's Jason Schuster. I'm a doctor of physical therapy. I own Intricate Art Spine and Body Solutions. It's a continuing education company teaching other doctors how to do a couple things. Before that, I was a fly fishing guide in Patagonia, Chile, and southwestern Alaska for a decade. This is a clip from our Dry Needling 2 class. This is a great class. Check it out on our website, intricateartseminars.com. I've had lots of surgeons tell me, you guys, that they look at the needle and they're like, oh, that thing won't go through that at all, ever. They just say it'll bounce off the sheath that's covering those. Yeah, so that I was not as sure that this was a real thing, you guys, but I got actually a little bit pissed off in class not that long ago for the first time because it looked like one of the students had tried to catheterize their partner's jugular with a 40 millimeter needle. Like we were doing the SEM. And it was like a big jugular, like on Frank, that you can see. It's like, yeah, it's obviously. And they had this 40 millimeter needle. It looked like the entire thing was inside the jugular. And I walked by and I was like, what the fuck are you doing? And they freaked out. They're like, oh my. I said, it's not a big deal. The only way to know if you hit it is to take the needle out. So take it out and let's see if they get a monster zero blood. So then I've started thinking a little bit more, is like maybe that is more true than I gave credit for. I mean, they are surgeons. I do believe them to some degree or other, but I think that might be more true than we give credit for. So that just kind of FYI. I've never hit.
Do you think that the vessels are tougher to go through than a tendon sheath?
I don't think so, but I don't know.
We're trying to go through right into the tendon.
Correct.
Yeah, but wouldn't there be also, like the tendon is, depending on how it's anatomically sitting at that particular moment, is, it's pretty hard where these guys are just floating around.
Correct.
In the tissue, I think there's a lot more pliability.
Correct.
Mobility.
Correct. That's what makes more sense in my head, Ed, is, yeah, these things are much more mobile than tendons are. So if you happen to get it like right directly on the artery or whatever, the whole thing is going to be pushed backwards a little bit. And I think it's that's enough. And the sheaths are probably thick enough where the needle pushes it moves a little bit, and then it glances off to the side or something. All I can tell you is they're freaking hard to hit, you guys. I try to hit them all the time. I've given Angela a femoral artery injection with one of the functional medicine doctors. I was like, hey, can I do that? And you can just watch me do it. Because they were doing, it was right when we were trying to figure out what was going on with her, and they were doing some injections into her arteries that did help a little bit. But they do it exactly the opposite. They find the pulse, they put fingers on either side, take a syringe, they go in slowly, they wait to see when the blood starts pumping up into the syringe, they inject some stuff, wait to see if they're still in the artery. If they're not, they go. So they're poking that artery a couple of times depending on how accurate they are. So if you ever hit the stuff, it's not a big deal at all. Correct. Those are 2 millimeter hollow, big honking syringe needles.
They can't be bendy.
Yeah, they're not bendy. Yeah.
And they're cut in a way.
Yeah, they're whatever, they're beveled or however it is.
No,
yeah.
That's an important, and I think also just the way that we plant the needles, like we're not like just.
Correct. It's not like
we're for feedback.
Yeah, right. We're not trying to kill people.
If it hurts,
yeah.
then we're just going to adjust.
Right. Yes, 100%. That's what I think. So so we got that. So that's the only thing that we really want to avoid here, you guys. The other kind of, if you want to think about it as like a safety boundary or whatever, because with these needles here, I like to do them 2 different ways. I like to go straight down towards the table, more or less, if the person's on their back. If they're on the not, and you can do this and the psoas and stuff inside lying too, which makes it nice too, because you have access to both sides, at least on one side, you guys. But so I do needles straight into the leg here. So we don't want to be taking 75 millimeter needles or whatever and going straight into the belly here, right? So the ilioinguinal ligament is like the junction of all this stuff. It goes from ASIS straight over to pubis. So you can just kind of use that as a reference. And then the way that I do this, you guys, is whatever size needle I have, I keep trying to get the needle as far into the body as I can. So people always ask me, like, do you change your angle as you go around the leg? I just more or less keep going perpendicular into the leg. Or if you just want to think about just keep aiming for the femur. I just want to get, if we have the ability with needles to touch most stuff in the body, I want to at least touch it and see what the periosteum is like, or just in general, the deeper the muscle is, if it's pissed off, the more aggravated it gets, I think, because it's just harder to re-stimulate deeper muscles to stop being tight and hypoxic. So needling those suckers is what really, really helps. I can't tell you guys how many times, like I had a good story recently from this osteopath friend of mine, Chris. He's in Michigan. He runs a pediatric osteopath they have like 36 osteopaths up there, and he was like, man, I can't freaking believe how good the needling works. He said, I had this 18-year-old kid with like these weird MS type symptoms for the last 2 years, and Chris is a very good manipulator, so he does lots of manual work. He doesn't go to prescription stuff right off the bat, so I really like him. And he was like, I could get it to go away a little bit, and then it would come back, and I just, like, I've been treating him consistently, but we just can't figure out what it is. And he said, dude, the first time I did a psoas and multifidus needle on him, it absolutely killed him, and he was 100% better afterwards, never had that problem again. So I think that's a good example of how just enough muscular aggravation can give you like neurodegenerative type symptoms depending on that individual, where the muscle is that's pissed off, or just how their nervous system works. But Chris was thinking he had like some weird autoimmune thing, and it was just enough pissed off muscles around those nerves that were just giving him like these very unusual symptoms in his legs and stuff like that. Bilaterally, yeah. He said he was like having like these weird, very unusual neurologic symptoms. So that's how I do that area, guys, the psoas and the hip flexors. Any other anatomy questions or anything like that around here?
No, I'm definitely curious about this posterior one. I mean,
Sidelining approach, I've never done
I
that.
think
You haven't done that one? It's
I think a lot of
it's
times
easy.
I think I'm trying, not so much with the psoas, but definitely the QL. I quite often think about mid body of the muscle, not at the 12th rib, but I'll
Like in the middle of it?
I'll try to hit it on the ilium, but then quite often I'll go towards the spine and try to get in the middle of the body.
That's a perfectly fine way to do it, Frank. That's how I was taught how to do it.
Uh-huh.
That's Angela will do it that way. For me, I just like to always stay as close to the ilium as I can, because I think that's the safest way to do it. So I'm not saying you're gonna have a problem doing it that way, but I've never had any type of an issue when I've been needling people. I think this is one area where theoretically you could have a boo-boo if they had weird anatomy. So that's why I like to keep it as low as I can.
mean, I quite often think about that 12th rib, and then I go, oh, stay away from the ribs.
That would be one of the things where ultrasound would be awesome to have, because then you could feel confident.
Where you were.
Yeah. Without ultrasound, I don't.
I mean, I know that sometimes I'll do it, and I'm not necessarily, I got my finger on that 12th rib, and I'm like, okay, where am I? And if it's sort of hollow feeling, not hollow, but I mean.
That's how the
bone.
kidneys feel.
Yeah, I know, I'm not hollow, but like I'm, I won't go very far, and yeah, I don't know. I guess maybe I'm playing with fire there a little bit. But.
I think so a little bit. I mean, man, again, it's like we can hit that stuff at least once with these needles and not have an issue.
Yeah.
I think you can do that stuff probably most of the time without ever having a problem. I'm just worried about that one person that has a different anatomy that's a little bit unusual, or an organ in a weird. I mean, I just try to avoid stuff like that at all costs. So I think it's best to stay down there.
Okay.
That's just what I
get
think.
that. What if it gets down just for a second? Because we had a client that had lung replacement.
Yeah.
Yeah, transplant, and a lot of thoracic pain. As
Yeah.
you can probably imagine.
Sure.
Right? And we were needling.
I needled it all.
We were needling his paraspinals.
Yeah.
I don't recall that we went out onto the. Did you? You got some rib stuff there, but I mean we're using very short needles
And
too.
always at an angle.
So what's the question?
Well, I mean, going into those intercostals.
I don't go into the
I
intercostals.
know you don't teach it, but I mean, this was one of those situations where it was like, okay, this is super sketch, except for that this is what he needs, because this is what's so. I mean, we did not. At least I didn't do very much of this sympathetic stuff with him.
So I wouldn't. I don't think it's safe to try to needle intercostal muscles without ultrasound. I Again, that's one of those things that can you do it most of the time? Yes. Can you needle ribs most of the time? Yes. However, when the not most of the time is organs on the other side, to me, that's not worth it.
Yeah.
If it's like in the wrist, I have a totally different perspective.
Yeah.
It's like I'm fully fine with just poking needles straight past the nerves, arteries, and veins in the wrist, because the worst end case scenario is a bruise or a zinger. I don't care about that.
Yeah.
If the worst case scenario is an organ problem or a deflated lung, especially if they had a lung transplant, those lungs are going to deflate way easier than anything else.
Yeah.
So I wouldn't do that unless I had ultrasound. I would needle all the other stuff just like I would do on anybody else, but I don't needle the intercostals on anybody. So I wouldn't treat that person any differently than I treat my regular patients. Although that is, yes, those are super helpful muscles to needle. I wish I had a good enough ultrasound where I could, and they obviously exist. They're just a little expensive. Yeah. There's still, from what I've seen, you guys, I still haven't seen an ultrasound that is under $10,000 that you can really see the needle with. Like I had a friend of mine recently that had one of the smaller ones that transmitted onto your phone, and it was pretty damn cool, and it was good enough. You could see the tissue distorting where the needle was. Yeah. It wasn't nearly good enough to see the needle. So like I think we're still at 10 to 20,000 or more if you really want clear visibility of a 0.2 millimeter needle.
They're starting to do AI. Guided,
yeah.
AI
That's going to make it so much easier. Yeah. So I keep my eye on those machines, because at some point here in the near future, we're gonna, for maybe a few $1,000, you'll be able to get one that's good enough. So when that happens, I'm gonna get a couple of them and just start bringing them to class. But that's what stopped me, because like the ones I really like that I've used so far, like $70,000 or $100,000. Yeah. You guys let me know what you think about this. One of the things that I don't know what the right answer to this question is, one of the things that I go back and forth with Angela with sometimes is she's like, you repeat stuff too much. What I say is, Angela, I provide a monstrous amount of information to these people. I think that it requires repeating some things a lot, because I just know from like my questions from past students, like with this stuff in my brain, like I do this so much and I've done it for a decade that it's like, it is like so part of my brain that I don't ever need to think about this stuff. But I do have to like remember, it's like, this is a new thing for a lot of people. Do you guys agree that it's helpful to repeat stuff like that? And just kind of, because every time I talk about it, I say it slightly differently, or I describe it in a different, and I just think that I just know for me personally, like I need to hear certain things in a specific way sometimes, and it's like, oh, that makes sense now, you know. Thanks for watching, you guys. If you like this clip, keep an eye on my channel. Check it out on our website, intricateartseminars.com, or check out our school channel, school.com/CEU, SKOOL.com/CEU, to get a big discount on our dry needling bundle. It's a bundle of both of our online dry needling classes for a big discount.